All right. Ready to start. Morning, Gord.
Good morning.
Morning, Cal. Welcome to the FCIHR. So one of the celebrations of the Friesen Prize, Dr. Gordon Guyatt. I'm here on behalf, I'm a panel member on FCIHR, so it's my privilege to introduce Dr. Peter Lewis, who will explain FICIHR, Friends of CIHR, to you, and introduce Dr. Devereaux. Thank you, Dr. Devereaux, for chairing our guest panel today. And then we'll proceed. So, what to do, Dr. Lewis?
Thank you, Andrea. You all hear me? Yes, I can hear myself. So thank you, Professor Bauman. Andrea is actually VP on our Friends of CIHR, which I'll talk about in a moment. So I wish to thank you and the Faculty of Health Sciences at McMaster University on behalf of the Friends of CIHR for hosting the 2024 Friesen Prize program to honor Professor Gordon Guyatt. The Friesen Prize and related events are organized by this organization called the Friends of CIHR, which is a national organization focused on the support of health science in society. It was actually founded by Professor Emeritus Abby Angel back in the year 2000. And it turns out that was the same year that CIHR was formed, Canadian Institutes of Health Research. So this year, because it's 2025, is our 25th anniversary with CIHR. We're actually going to be organizing some events in Ottawa in the fall. FCIHR advocates on behalf of young people as career scientists and encourages the funding of health research in Canada. We are supportive of the goals and ideals of CIHR and other health funding agencies in Canada and are eager to recruit young people to our activities across the country, and I'll actually have some comments to make about that after we have our events. This year, as you know, we're honoring Dr. Gordon Guyatt, the 18th Henry G. Friesen International Prize winner. And I will just say, if you don't know, Henry Friesen was the key individual who, from the University of Manitoba, who helped create CIHR. From those of you of my age may remember, there was also another organization called the Medical Research Council, and Henry was able to, together with government and funding and various people, to create the CIHR. And so Gordon, one more thing, sorry. So as a consequence of Henry Friesen's activities around creating CIHR, in 2005, the Henry Friesen Prize was created by Dr. Angel and became the key event, really, the picking of the awardee for the Friends of CIHR. So Gordon Guyatt, as I said, is the 18th Henry G. Friesen International Prize winner who was selected for his pivotal role in developing the concept of evidence-based medicine and advancing its application to medical education, research methodology, and clinical decision-making. So in addition to the events today at McMaster, Dr. Guyatt will be visiting with me in June to the University of Manitoba, and then at the end of July, the University of British Columbia. So as Gordon will attest, it's an 18-month process, and we will this year have visited 8 Canadian institutions. where Gordon gives a lecture and then has some event like this, a panel discussion around the topic of his research. So today we're celebrating the 2024 Friesen Prize awardee, the 18th, and we're very grateful to Gordon for accepting the obligations. You can tell it's not a light set of obligations, including a book that we're going to be publishing shortly. So a brief biography of Dr. Guyatt is provided in the announcement you've probably seen or have in the program. So I'm not going to go through the details, but I will highlight that through his long career, Dr. Guyatt has had a profound influence on the development and implementation of the concept of evidence-based medicine. He is an inspiring, visionary scientist, clinician, teacher, and communicator. So one more time, thank you for accepting the 24 Friesen Prize. So we look forward to a panel discussion about evidence-based medicine, what has been successful, what are the challenges. And the panel discussion will be chaired by Professor P.J. Devereaux. I won't list the panelists because you're going to introduce them, but I will say Dr. Philip James Devereaux is a prominent Canadian cardiologist, clinical epidemiologist, and perioperative care physician of McMaster University. And I will comment, I didn't know exactly what perioperative meant, but I do now. So anyway, that's great. He is a professor in the departments of health research, methods, evidence and impact, HEI, and medicine. And additionally, PJ is director of the Division of Perioperative Care and senior scientist at the Population Health Research Institute, where he leads the perioperative and surgical research group. So over to you, PJ. Thank you.
Thank you, Peter. It's a great day. We came together today to celebrate an up-and-coming guy. My talent is recognizing potential, and trust me, this guy has some potential, but we'll wait to see what happens. So huge congratulations, Gordon, and huge thanks for your mentorship and friendship and all you've contributed to advancing science at McMaster. We're going to have this panel, so everyone's going to have sort of 3 to 5 minutes to present on their topic. And then we're going to open up to the group for comments or questions anyone wants to pose to anyone on the panel or Gordon. I'm not sure in terms of the panel, we have a mic we can hand around just so that it'll be more functional in terms of people responding to the questions, because the people online, just to make sure everyone can hear what's online.
Yeah, there's a front of house mic. It's with those small lapel mics, but
okay, perfect. If we could have that. Okay, so I'm going to introduce the panel members, and then folks will come up and give their presentation. So I'll first introduce Sharon Castellanen. So Sharon joins us second from the end there. So Sharon is a professor in the School of Nursing and associate member of the Department of Family Medicine, McMaster University. She is also an honorary professor at Queen's University, Belfast. And then Liz Darling, sitting right beside Gordon. Liz is an assistant dean of the midwifery program and a professor in the Department of Obstetrics and Gynecology here at McMaster University, and she's also an adjunct scientist at ICES and a registered midwife. And then Mitch Levine in the middle here is our czar of our HRM program. So Mitch is the assistant dean of the graduate program for health research methodology in the Faculty of Health Sciences. He's a professor in the Department of Health Research Evidence and Impact at McMaster University. And then Rebecca Kuhn, who's at the end here, is a first-year PhD student and a family medicine physician and junior researcher at McMaster University, and I believe working with Gordon and doing her training. Finally, Peter Lewis, who was kind enough to lead this process and introduce Gordon, is the interim president of the Friends of CIHR. He is also professor emeritus in biochemistry at the University of Toronto and the board chair for the Charles H. Best Foundation. So thanks very much, and I'll turn over to folks to give their 3 to 5 minutes.
How do you want to start? So Liz.
So good morning, everyone. I'm going to organize my comments about the challenges and successes of evidence-based medicine around three main concepts: values, equity, and complexity. So while patient values are considered one of the three core components of evidence-based medicine, the focus on high quality, i.e. rigorous and objective research in evidence-based medicine can be accompanied by a lack of acknowledgement of the broader impact that values have throughout the process of evidence-based medicine. Michael Kelly and his colleagues have done a nice job summarizing these impacts in their 2015 article entitled "The Importance of Values in Evidence-Based Medicine," which was published in BMC Medical Ethics. As Kelly and his colleagues described, values shape the research questions that get asked, the decisions about which of these research questions are funded, the methods that we use to identify and appraise evidence, how clinicians interpret and apply evidence, and how they approach shared decision-making with patients. One example of the success of evidence-based medicine in making the impact of values more explicit is how a grade methodology, which is used to evaluate the quality of evidence in systematic reviews and to develop recommendations for clinical practice guidelines, incorporates an explicit consideration of values and preferences. As a midwife, my values are closely aligned with that of my profession, which highly values patient or client autonomy. And from that perspective, I see our current healthcare system as not always enabling the conditions that support clinicians to have meaningful involvement of patients in decision-making. So this remains a challenge for evidence-based medicine. The impact that values have on what research gets conducted leads nicely into the second concept that I'll address, which is equity. So in 2025, we can probably all readily agree that if a particular group of people are systematically excluded from RCTs, this will result in inequities between groups in the availability of relevant evidence to guide healthcare. Yet back in 1977, with the tragedy of thalidomide in very recent memory, the FDA recommended that all women of childbearing potential be excluded from early-stage drug trials. This policy exacerbated existing underrepresentation of women in clinical research, and it roughly coincides with when concerns were first voiced about inequities in who was being included in RCTs. In the US, these concerns eventually led to the NIH Revitalization Act in 1993, which required women and racial and ethnic minorities to be included in NIH-sponsored trials. And funding bodies in Canada and Europe have subsequently also directed research to be more inclusive. So I didn't have time to do a systematic review of the literature to prepare for this talk, but a rather quick search suggests that there have been significant improvements in the participation of women in RCTs. However, when RCTs are grouped by different areas of medicine, imbalances between male and female participation persists. Older women remain underrepresented in RCTs. Trials are not always sufficiently powered to conduct sex or ethnicity stratified analyses, or these analyses are not done, and some ethnic groups remain underrepresented. Successfully addressing these inequities will require both researchers and research funding bodies to value and prioritize conducting and funding research that intentionally and rigorously incorporates sex, gender, and ethnicity-based analyses. So finally, I will jump from the complexity of health inequity to a more general comment about how complexity complicates the generation and interpretation of evidence. EBM works really well for interventions that can be delivered in a pill. But many healthcare interventions, from healthcare programs to surgical procedures, involve multiple interacting components. They may perform differently in different contexts, and they have no placebo comparator. So many of us involved in healthcare decision-making will also need to use and interpret evidence that does not come from RCTs, systematic reviews, or clinical guidelines. Fortunately, the methodological developments of evidence-based medicine have inspired methodological thinking about complex interventions. And a great example of this is an updated framework for developing and evaluating complex interventions, which was commissioned in the UK by their Medical Research Council and the National Institute of Health Research and published in BMJ in 2021. So while evidence-based medicine cannot be easily applied to all clinical decision-making, it is a concept that has stimulated refinement of how we best generate evidence to develop, evaluate, and implement complex interventions, and therefore has informed important adjacent and complementary areas of health research.
Good morning. So in my few minutes, I'm going to talk about how evidence-based medicine has changed over the past 40 years. So 40 years ago in the 1980s, the real focus of EVM at that time when it was starting to come to fruition was really very physician-focused. There was some patient focus, and it was a lot about bedside clinical decision-making for the physician involving the patient. And the threshold for acceptable evidence was what was really focused on, and to include some patient values and to avoid the anecdotal use, or the use of anecdotal evidence to drive decision-making. And so that was the negative of to what had to be put to the side. A lot of the focus at that time was on interventions, which said that they had to be RCTs or diagnostic tests that should have been validated, and or to use things like likelihood ratios for the imperfections of diagnostic tests. And the academic activities were focused on training physicians with critical appraisal skills, and for researchers, encouraging them to create what was considered good quality or high quality evidence that would assist in decision making. 10 years later, a decade later, in the 1990s, phase two expands. So they're no longer just very physician focused, but now we're talking about all healthcare providers need to endorse and use and have the evidence to make clinical decisions. So it gets involved with physiotherapy and midwifery, nursing, and a lot of other healthcare professionals. And I'd also say they also focus back on certain physician groups that were reluctant at the beginning, a lot of surgical specialties that didn't endorse evidence-based medicine when it first started. And the other thing that it also expanded to in terms of target audiences were policymakers. So, for example, the Drug Quality Therapeutics Committee in the province of Ontario endorsed its decision-making process would have to be evidence-based. So this was now even into the realm of policy. There was also, the other thing was the transformation of accepting that sometimes you can't get the best evidence possible, and so that we needed better methods to address how you would use the best evidence, because was less than possible. And so using observational studies, but developing methods to try to articulate what was acceptable and unacceptable in these lesser, perhaps, evidence creations. 10 years later, phase three, you now have an abundance of evidence out in the world literature, and clinical decision makers needed evidence synthesis to help them manage this huge amount. We were no longer looking at single trials to kind of the guide. It was the evidence synthesis and the meta-analyses, systematic reviews that were really the source of evidence for clinical decision making. And then the final phase is phase four, which has really been the last 15 years, is just the absolute explosion of guidelines, which were based on the systematic reviews, and the systematic reviews, of course, based on the individual studies. And so now we're into the era of guidelines development guiding clinical practice, evidence-based practice. And it's no longer even just focusing on individual patient-physician interactions, or patient healthcare provider interactions, but the guidelines often focus on whole specialties or policymakers to guide them with evidence in what they do. And that's 40 years.
Great, thanks. So I only have 30 years, so I should take less time than Mitch. So I'm going to talk to you a little bit about some of the work that I've been doing over the past 3 decades in the long-term care sector. So started out during my PhD, and before that, developing a pain assessment tool for people who have dementia. And over probably about 5 years, did a lot of psychometric testing, and we got to a point where we had the fairly strong tool that we thought we could use to assess for pain. And I thought we were done. I thought, great, we've solved the problem. But soon realized that was the easy part. The hard part was getting it into practice. So the next part of my few studies after that was to learn about the context of long-term care, some of the challenges of implementing evidence-based practice, implementing new tools and innovations, And it probably was the most important part of all of my research that I've done to date. In long-term care, if any of you have worked in long-term care, it's a very unique setting. So we have up to 80% of the staff who work in long-term care are personal support workers, have at the most, I would say, a year of formal training. Physicians at the most would come into long-term care on a weekly visit to check with residents. And nurses really are the sole decision maker when the physicians aren't there. Also, you know, I've heard recently it's the second most regulated sector compared to the nuclear industry. So surprising, I'm going to have to look up, speaking of evidence-based, I'm going to have to look up that stat. But I'm not surprised, and particularly in Ontario, very, very hard. I've had a couple of discussions last week with people trying to implement new interventions, and we're so constrained with these regulations, and it's almost like, you know, it's more of a punitive environment, and there's not a lot of, I would say, positivity when the inspectors come into long-term care. I hear from administrators that they comment more about the light bulbs being wrong, as opposed to some of these great new interventions they're doing. So it really, really is a challenge. I've persevered for 30 years. I'd like to think we're moving a little bit forward. But what I have learned over the years, the importance of working closely with the staff, the residents and families, and really contextualizing all of the research that we do to suit the setting. And it's, you know, the other piece with long-term care is they tend to be very segregated. There's a lot of ageism in place in our society. So how can we help empower the sector, the staff, the residents and families as we try to apply evidence-based practice? So that really is fundamental. What has carried me the last 20 years, all of my work is participatory action research. We're just finishing a large RCT in 3 provinces, evaluating one of our programs, implementing a palliative approach in long-term care. And I can say the success really is about the relationships that we've developed with the homes and the staff. It's really critical to make any kind of change in long-term care. I've had the privilege of a Career Scientist Award, so I've had the opportunity to also work at the policy level in Ontario in particular, and helping inform some of the inspection protocols around pain management, and really trying to leverage opportunities that are in the system. For example, at one point in my career, I was working with Dr. Alba DiCenzo, a big call out to Alba who's here, who was starting to look at nurse practitioners. They emerged in the 1990s in long-term care, or 2000s actually. So I took that opportunity to do a postdoc with Alba and look at how we can leverage this new opportunity in our system to implement the nurse practitioner role with, I would say, pretty good success. And we still have nurse practitioners. In fact, we're getting more funded every day. So really, you know, trying to work within the system, within the current environment, and leveraging every opportunity and relationship to really advance evidence-based practice in long-term care. And hopefully by the time, you know, I need long-term care, it'll be in better shape. I hate to say that's my goal, it's really not, but I'd like to think that when it's my time, that it will be in better shape because of all of the research we're doing in the sector. Thank you.
Hello, everyone. I must say that I do not have 30 or 40 years of experience in evidence-based medicine. Perhaps I have 3 or 4 at a stretch, but I would love to talk to you all today about a component of evidence-based medicine that I think is wonderful, and that is systematic reviews, and how I've seen that change the lives of many people around the world. So I really was exposed to the importance of evidence-based medicine and systematic reviews and guidelines when I was a clinician working in the Gambia. This is a very small country in West Africa, and this was during the COVID-19 pandemic. And I can distinctly remember a young woman coming to me with a very clear clinical diagnosis of rheumatoid arthritis. So for anyone at home or listening in online doesn't know what this would be a lifelong condition. She would need medication for the rest of her life. And so I dutifully went to our hospital's supply cupboard, opened it up, and I was sort of confronted with this tumbling, chaotic mix of medications. And to be quite frank with you, I didn't know what they were. They were old medications, perhaps from 10 years ago in rheumatology. I simply didn't recognize them. And it struck me at that point that I did not know the comparative harms and benefits of the medications in front of me. And that was exactly what I did need to know, and I didn't need to know it. And I didn't have the luxury of looking up any clinical guidelines that even potentially had these medications anymore. I assume they'd been donated to this small underfunded hospital. And then there I was, quite stuck. And I realized how important it is. What I'd taken for granted is the evidence and the science behind the medications or the treatments that we all use today. So this led me to take, and just as well as that, not only could I not counsel my patient about the harms or the benefits, what side effects she could expect, could she even decide for herself, is this medicine going to do her more harm than good? Tying into what Dr. Darling was saying about patient values and preferences, she may have even elected not to take this medication at all, given the potentially devastating financial consequences on her family in the particular context that we were working in. So tying into that whole principle of patient values and preferences. So I really was in a stuck position and realized how crucial this field was. So this led me to take a position at the Liverpool School of Tropical Medicine in the United Kingdom. And there I worked as a systematic reviewer within the Cochrane collaboration, working with the systematic review methodology, which essentially is an evidence summary. So pulling all the research together on a particular research topic. So a patient, a clinician, a policymaker can decide, okay, what are the risks? What are the benefits? Add my own values and some certainty of the evidence, of course, for them. And then they can make a decision about that treatment. And what I love about evidence-based medicine is that whilst I'm fortunate or I've come into this field when systematic review methodology has been vastly developed, it does continue to evolve and new gaps open up that we need to meet as the world moves forward. So when I was working in this research position in Liverpool, this was the post-COVID era, and then this, for example, this new condition was coming forward called long COVID or post-COVID condition. And this was a very devastating illness. There was multiple symptoms in multiple body systems. Patients, clinicians all needed to know, how do we treat this seemingly new condition? And there wasn't much evidence and we needed it. But the group I was working with could apply the systematic review methodologies to this particular problem. And because there were many theories flying around, one of these theories was that small so-called microclots in the blood were blocking the small capillaries, leading to the symptoms of long COVID. So we wanted to assess whether that theory was potentially accurate, because patients, I know in the UK, were quite desperate. Some people were even mortgaging their homes to seek a treatment called plasmapheresis, which is where the blood is filtered and these so-called microclots are removed from the blood to then potentially alleviate the symptoms. So our group looked for any trials using these core scientific principles to see, did patients get better if you did filter your blood as opposed to not filtering your blood? And of course, these trials didn't exist. So this was another challenge, and we were actually reduced to looking at the actual laboratory studies. So where investigators had taken the blood of patients with long COVID and those sometimes without long COVID and compared and looked for these so-called tiny microclots in the system. That was a challenge in itself. That's quite a low level of evidence. And we'll hear in Professor Guyatt's talk about the levels of evidence. So we were sort of at rock bottom, but we could apply these really credible, scientifically defensible methods to appraise the evidence that we did have. This involved creating a new risk of bias instrument applicable to laboratory studies in this particular instance. So using these wonderful scientific methodologies, we could come up with a systematic review or an evidence summary of what we had, so patients could then see what were the harms and benefits of potentially undertaking this treatment that was not without harm. And that's what I love about evidence-based medicine. So if anyone needs to be recruited, come and chat to me, because you can see how these evidence summaries can really change the lives of potentially millions of people around the world. And that's just one component of evidence-based medicine.
Peter. Well, no, do you want to say a few words?
No, I'll say something.
Yeah, absolutely. Okay, well, thanks very much to all the panel members for those insights. So we want to open this up to group discussion, rebuttals, questions, comments, anyone's thoughts? Sonia.
Thanks, everyone. Congratulations, board. I'm wondering if you could give us your perspectives on evidence-based medicine in the era of disinformation. How can we do better at kind of countering disinformation with evidence-based information?
Gordon, do you want to take that on?
Yes, so I am often asked questions like you're asking, Sonia, and I immediately think I am completely unqualified to answer the question. Now, I wouldn't even know what branch of social science would be most relevant. Is this a matter of psychology or a matter of sociology or political science? I would suspect maybe all three, and maybe other social sciences, none of which I am qualified to speak about. On top of that, as an evidence-based guy, I would think there must be some evidence out there to address your question, but I don't know what it is, okay? And this is, I have shifted to the answer. It used to be people, I don't know, 10, 20 years ago, people would ask me this question, and I would forget the fact that I was completely unqualified to answer and didn't know the evidence, and I would spout off and say whatever came into my head. I have now said that I should model evidence-based approaches, recognize when I don't know things, recognize when I don't know the evidence. Having said all that, I will nevertheless speculate a little bit in terms of something I do know a little bit about, which is my belief that what we need, the counter to disinformation, is that we need a public that understands how to think about evidence. And until we have that, it's going to be really difficult. And where should we start with that? And I'd like to refer to my colleague and good friend, Andy Oxman, who has said, okay, we need to be able to teach people at an early stage of their training to make informed health choices. And he made a interesting place to start. He did it in East Africa, in impoverished settings, where he randomized schools to get his programs of informed health choices. And he did a big cluster randomized trial and showed that you could teach African young school children to make informed health choices when he tested them. The most interesting finding of that, or at least one of the most interesting that I found, was that they also applied their tests of making informed health choices to the parents of the kids in the study. The kids in the intervention schools, the parents did better. The kids were going home and teaching the parents. The message of this to me is, if you can teach it to African school children in those settings, you can teach it to anybody. And but it's very difficult to me to combat this information if people don't know, have no idea about the rules of distinguishing trustworthy from untrustworthy. And really effectively addressing that would be to implement it in the education systems. And Andy has shown that you can do it right at the start. And somehow we need to do that.
Anyone else on the panel want to comment on that? Gordon, it's great that you've progressed to restraint. Okay, any other comments, questions? Yes, Andrea.
I have a question of Dr. Castellani. It was interesting about all your work in long-term care and some very good science and very good writing. Why do you think it's so slow for governments to adopt some of these clinical guidelines which only enhance care?
Come up there.
There you go.
Thanks, Andrea, for that question. I think part of it is about priorities. And for some reason, the long-term care sector is really under scrutiny. And there's a lot of media that comes out around people falling, people, dying, residents pushing one another. And I actually think it's more fear, the government, not wanting some of these stories to get out. Ultimately, they're responsible. Interestingly enough, I've worked with probably 5 or 6 different directors of long-term care. They don't last more than 2 or 3 years. So I don't think it's a really popular role is to, oversee the long-term care sector. We're really afraid of risk. That's the other piece. I just came back from a trip to the Netherlands and was able to visit some of the really neat care models they have there for long-term care, green care farms, these dementia villages. But they don't have the same feeling about risk. It's about freedom and people's, own right to choose what level of risk they want. So I think we're not there with the government. I think we're really afraid of, we're really risk averse in Canada, actually. And it's really hard to move forward when we're more afraid of, someone falling than trying to promote them walking. So one of the things I noticed and I heard when I was in the Netherlands, residents are walking up to 2 weeks before they die. But in Canada, I think we get them in the wheelchair as soon as we can so they don't fall. And then they decondition, and it's just, it's not great. So we have a lot to learn, I think, from other countries. And my goal is to try to help inform governments and nudge them a little bit to try some new ways of trying to improve quality of living in long-term care. Thanks.
Also, there's over 30 people online. So if anyone online wants to ask a question, please just put it in the chat and we'll get to it. Jan.
Thank you. Maybe for the entire panel, with emerging technologies such as large language models that have obvious implications for evidence synthesis, how do you see their role in bridging the gap between clinicians and patient values next 5 to 10 years?
So that's an interesting issue when at the end, you talked about bridging the values. And the problem with the AI as currently is its values are based on the people who are putting in the information that it's learning from. And so I don't know how you now get the inputs to be from the 2 groups you just described, that they're going to be the conduits for the information that gets into the AI, that it learns those values. I think it's a huge challenge. I mean, we could go off on a whole other discussion about the evils of AI in terms of not actually doing what we think we want it to do.
Yes.
I have a question of your minutes, if one wants to put the information in it as well. Like my question is regarding you talked about the FDA new regulations that they're removing pregnant women, 3-month pregnant women from research studies. So to me, it seems like greater risk for those women and the kids. So why would you consider it as risk of inequity? Like, or what would you consider a SWOT skill?
Okay, just to clarify, the FDA regulation was required women of childbearing potential not to be included. So it basically effectively wiped out a few decades of women participating in research trials and a few decades of their age span. And so I think that creates a huge gap. And I think there also are ways of minimizing the risk of somebody becoming pregnant if they're participating in a research study. So that's definitely an option. So I think there really are big equity issues in not having, women in a few decades of their life being able to participate in studies. And that was historical, right? So that was 1977 we're not seeing that happening really in most situations these days. I think there is still hesitancy around involving pregnant women in clinical research. But I think if we exclude them, then we remove the potential to generate really important evidence that might prevent harm to future pregnant people and their offspring. So I think it is important to actually have research that is specifically done that includes pregnant women. And we saw some evidence of that even in terms of COVID-19 and the vaccine, that once we started to generate evidence about that, we actually found that there were big benefits, both to the people who were pregnant and to their offspring if they were vaccinated. And if we didn't have any evidence to be informing those decisions and just worked sort of from a precautionary principle, then we actually would be creating more harm by not allowing that intervention to be made available to people in pregnancy.
I'd like to add to that one. So just to reinforce this, I've been working in a lot of WHO guidelines, particularly guidelines on COVID. And every time we are coming up with, when we look at the new interventions, what do we say about pregnant individuals? And the pregnant individuals have often been excluded from the trials or under-recruited from the trials. And what do we say? And it seems absolutely like the wrong thing to say. Don't offer pregnant women these interventions that we know to be effective in other populations. But it becomes much more difficult because it is unstudied and it becomes speculative as to what we should do. And so we say, think about it under the circumstances of having little that is applicable. Surely it should be far better when we know that women and their unborn children could, as you've said with the vaccines, benefit. They cannot be excluded from these, rather than keep them out of the trials and then end up at the end when it comes to a guideline panel being completely speculative, but surely saying, surely the right thing is don't give them any treatment. That's surely the wrong thing to do. But then we have to speculate. Surely it would be better to include them in the trials, knowing that they, like anybody else, have a good chance of benefiting.
Liz, one of the things that strikes me about this issue is that if you take CIHR as an example, there's been an enormous focus on pushing the issue of we need sex-based subgroups and that we really know nothing unless we have these. And yet it is a huge equity issue that women and women of childbearing potential have been enormously excluded from trials. And that's not been the focus within this actual debate. It's been all on let's make sure we get sex-based subgroups, even when there's no biological rationale for it, and ignore the fact that we're very prone to erroneous subgroups on this. But I think the problem we have is that obviously women who are of childbearing potential are going to develop illnesses. And if we don't have them in trials, then we're stuck with, we're not sure what to do. But I think, Gordon, it is more complicated, that obviously it depends. It's an issue of childbearing potential versus you are pregnant. And obviously there are some drugs, and there's people doing work in this. Natalie Down has a big funded CIHR program right now that's focused specifically on this, of when is it credible that, yeah, this is not unreasonable that we can inform women, make their own choice, they want to be part of it. But there's some drugs which are highly probable that in fact they're going to be high risk, and it may not be worthwhile for people to expose themselves to it. And we need to find other solutions in those illnesses. But I've been very struck at how we've put the argument, we've politicized sex, but we've ignored this inequity issue of women being excluded from trials.
Yeah, and I think maybe you sort of touched a little bit on what is part of how we can develop a bit of more nuanced solutions around this. So we need to look at other grades of evidence where we have evidence about drugs of similar categories, for example, and make informed decisions around where might there actually be a risk to women participating in a trial that we might think is unreasonable, and then more proactively using the existing other forms of evidence that we have to justify when we should be including women.
Any questions on that? Okay. Huge thanks to the panel, especially the moderator. No, sorry. Building on the questions related to the disinformation, I'm curious about the role of uncertainty While there are many things we can feel fairly certain about, there are also gray areas, especially around complex social problems. As we saw during the COVID-19 pandemic, a source of mistrust was changing guidelines as evidence emerged. How can we collectively become more comfortable with uncertainty and hold space for nuance? Anyone want to say that? Or
So here again, how can we be more comfortable about uncertainty? And I immediately think, how are we going to measure comfort under uncertainty? And what has been studied about comfort under uncertainty, and what has been studied about making people given more comfort about uncertainty? And the answer is, I don't know. Okay, so maybe there are studies out there about making people more comfortable about uncertainty, but if they exist, I don't know about it. So what I'm emphasizing in this and my prior thing is that evidence-based thinking, when it gets into your blood, you stop and think, okay, what do I actually know about this, as opposed to completely speculating. So I can tell you that it is a big challenge to incorporate uncertainty and to how to deal with it in decision making, and we're still working on even ways of incorporating it in our studies and helping patients deal with the concept of uncertainty. So as far as I can see, we're a long way from having much evidence about how to make people more comfortable with uncertainty.
anyone else in the panel want to comment?
So again, with the caveat that I like Gord, I'm not an expert in this area. I think, to me, it makes me think these might be areas where we want to branch out and be including other disciplines as we think about ways to maybe develop uncertainty. I think of, maybe we need to look at things like Buddhism, like that's an approach to living with uncertainty. But that aside, I think the other thing too that is probably important in terms of developing comfort with uncertainty is that it starts, I think, with the clinicians. And if patients are uncomfortable with uncertainty, they won't be comfortable with uncertainty if clinicians aren't. And so I think that those would be questions to think about. How can we build comfort with uncertainty in healthcare professions? And I think that's a question that as an educator is something that we do think about. And often when people come into their studies to become healthcare professions, they're surprised to learn how much we don't actually know and how much uncertainty there is. And so I think as educators, we need to think about how we do a good job of that and how we teach clinicians to deal with that well in their interactions with patients.
Mitch?
So maybe that's the fifth phase in the 50 years of evidence-based medicine. We evolve from, just like physics went from Newtonian physics to quantum physics, we have to go from kind of evidence-based medicine, which thinks it gets it right, like there's a right and a wrong, to the uncertainty of evidence-based medicine, and that's really what we have to adapt to. I have no idea how we achieve that, but I think that's the frontier.
Great point. Gordon, do you want to add to that?
Well, I'm not sure, Mitch, it's the frontier, in that I would say it was there very much from the start. And in fact, one of the sociologic things that happened with EBM was that it highlighted right from the beginning, it highlighted the uncertainty around most of what we do clinically. And part of the resistance to EBM at the beginning was clinicians who had been for things like on the basis of physiologic reasoning, thinking they were confident about things, and then being told that no, they aren't confident, and finding out repeatedly that things they thought they were confident about, when you test them, they had good reason not to be confident. And that was one of the major discomforts and pushback that we got, I would say, around evidence-based medicine from the beginning. Again, I would say, I think over time, just being out there, people have got more comfortable with uncertainty than they were, because you see an up-to-date, 2/3 of up-to-date recommendations are weaker conditional recommendations, meaning we're not sure, okay? And so I think that there may still be some resistance, but just having it out there over and over and over again, that most of what we do has a substantial amount of uncertainty in it, people maybe are getting used to it.
Yes, Andrea.
Just have following up on your comment, Gord, a question for Rebecca. Rebecca, I think your doctoral work is in bias and also uncertainty and therefore decision-making, the earlier Tversky-Fanlin work. What would be your comment on the role of bias and disinformation? Are they closely aligned, do you think?
Oh, it's a good question. So like my understanding of bias is, looking at a study, it's how it's designed, how it's conducted, and has anything in those processes led the study to conclude something that's misleading, essentially. And I think that's a critical part of any research study. So say that study had a low risk of bias, was very well conducted, it may still not lead to a certain answer, so to speak. It may still say, we don't know, even though the studies were quite well conducted. I suppose that's possible, depending on the type of evidence that you've got. Yeah.
Thank you.
Yeah.
Stephen.
Okay, I'll introduce an anecdote, but it does provide evidence about dealing with uncertainty. This is to do with a study that Gordon was briefly involved with, but led by Deb Cook, where we were presenting physicians who are working in the ICU with patient scenarios of people who are quite seriously ill, and the physicians were asked about the recommended therapy, ranging from full support, let's get out of here, to pull the plug. So we had a range of these scenarios. The results showed basically that the recommendations depended much more on the physician than the patient. There was an unusual bimodal distribution. Some people were recommending full support, other people were recommending do nothing. And the most interesting thing about it was when we asked them, the physicians, about the confidence that they had in their recommendation, they were all very confident. So they disagreed substantially with their colleagues. And if you end up in the ICU, the therapy you get may have to do very little with who you are, but who your physician is. A little bit of evidence for you.
Sonia.
Just wondering your perspectives on behavior change in evidence-based medicine. So evidence-based medicine is very logical. It's logical. I wanted to ask you, Gord, if you make any decisions with your gut feeling or not. Not sure. You can tell me later. But the question is really in behavior change, where we have pretty good evidence for some things like smoking cessation or exercise and dietary change. We can present it very logically to patients, but humans don't often make decisions based on logic. And I see this all the time in the clinic, where a patient will say, it's more an emotional reason whether they choose to take a drug or not, or what their neighbor told them, rather than what the logical evidence is. Are there any ways around that? Are there any ways to leverage the emotional decision-making and EVM to get patient or the individual where you want to get?
Did you want to start first? You go ahead. I disagree when patients make these, what you refer to as illogical decisions, that they're illogical. I mean, unless they're psychotic. Because, well, that's just it. So it's based on, their decision, they're using that information, and there's other things that matter to them. And it's very logical for them to make the decision you think is illogical, because it makes sense from their perspective. And that's we're individuals, and we have values, and that's when the values are a very important part of the final decision-making process. So I don't think that there is a way to say we're going to cram this evidence into their decision-making and get them to follow it. So I just don't see any way.
Much along the lines of what Mitch said, Sonia, there were a few things that you threw in there. One was, my neighbor took it and it worked, so that's why I'm taking it.
Didn't work. had
Or
side
didn't work,
effects.
and so I'm not going to take it. That does not have, that has, to me, has nothing to do with emotions. That has to do with what I alluded to previously, which is they have not been trained in terms of making informed health decisions. In other words, their notion of, if you told them what a randomized trial said, they would not be in a position to give the appropriate value relative to what happened to their next door neighbor. So that's not an issue of being emotional. That is an issue of not understanding appropriate rules of making inferences about health interventions. So that's number one. Second, related to what Mitch has said, how do we distinguish between values and preferences versus emotions? And I'm really not sure whether you're talking about emotions or values and preferences. Certainly, if I understood what you just said, Mitch, a value in what one person may say, for instance, I enjoy smoking so much that I'm going to keep smoking despite the problems with smoking. I wouldn't say that's emotional. Emotions play a part in just about everything we do, sure, but that's a value and preference decision. And so Amaran Gaffney told me this one, which I really like, which is a patient is making a decision, and and you say, okay, well, a few people get these serious side effects, but it's only a few, and look at all the benefits you get. And the patient says, doctor, in my life experience, I know if there are side effects, I'm going to get it. Okay, and that was that is the patient's experience. Is that emotional, or maybe that is certainly their experience? Maybe they're right. Maybe they are just the susceptible individual. So what seems illogical? So the point being, what seems illogical to us may be the three things. Number one, they don't understand the rules of deciding. They have a very distorted or misguided idea about how to judge whether things are beneficial or not. It's actually their underlying value. It's not an emotional thing. It is in fact their underlying values and preferences, or they have experiences particular to them that are in fact logical in their world, although they may not seem logical to us. So those are, I would say, three things to keep in mind to distinguish between what is emotional and things that it isn't emotions, it's these other three elements.
I'm using emotional because my psychology colleagues do. I don't know if anyone here from psychology wants to weigh in, but
well, the three things that I listed, the three things that I listed there, would you call those emotional?
it could be a Venn overlap with maybe category 2 and the values and preferences.
Yeah,
But,
I mean, obviously emotions affect everything we do, but I think it's worth, the classification that I just came out is worth keeping in mind when you think about what's actually happening.
But perhaps we can agree, based on even Stephen's example, is that ideally, as physicians, and it's not always easy, and there's all kinds of constraints that make this difficult, we should be divorcing our values and preferences and really basing upon patients, because there is real variation in how we all weigh and see things, and getting to at least that place of we need to move a lot closer to the patient's values and preferences and not our own, would hopefully be a step in the right direction. Anyways, this brings us to our timeline. So I'm going to turn back to you, Peter, at this time. Thank you very much to all the panel members. Huge thing for your
Yes, it is great. So thank you. This has been a fascinating discussion. As a basic scientist, this is all kind of hazy to me, but every time I hear the discussions, they're very informative. So I want to thank PJ for chairing the panel discussion and the panel members, including Gordon, of course, for participating. I would be remiss if I didn't mention we have two noteworthy individuals in the room. Professor Sonia Anand, who is AVP for Global Health. Welcome, Sonia. And also Professor Dina Brooks. There you are. Who is Executive Vice Dean and Associate Vice President Academic. So thank you for joining us. We now have a break till 1 o'clock, and then Gordon will be giving a formal lecture then here, I believe. So thank you. Honored to have Professor Sonia Anand, who is AVP of Global Health. So thank you for joining us, Gordon.
Okay, thanks very much. We're going to talk about the past, present, and future of evidence-based medicine. I'm going to describe what I think are the three key principles of evidence-based medicine, and I'm going to use a historical approach in which I'm going to introduce you to some of the major players who have been made evidence-based medicine what it is today. I'm going to talk about the evolution and evidence-based medicine in the time of COVID. So this is the first paper where the term evidence-based medicine appeared in the medical literature in 1991. And to give you an idea of just how long ago that is, that's what I looked like at the time this paper was published. The first person I'm going to introduce you to is Dave Sackett. He was my mentor and the mentor of many of the other leaders in evidence-based medicine, and he made a number of contributions, one of which was to suggest a simple hierarchy of evidence for therapy, more differentiating between more and less trustworthy. This hierarchy acknowledges that our clinical experience is a legitimate source of evidence, but subjective, that basic research and observational studies focused on patient-important outcomes can contribute, but are all limited. And so at the top of the hierarchy is randomized trials. Excuse me. This is a very simple hierarchy, and later on in this talk, I'm going to introduce you to a more sophisticated hierarchy, which has come along as evidence-based medicine has developed. The next gentleman I'd like to introduce you to is Ian Chalmers. Ian Chalmers' major contribution to evidence-based medicine was the recognition of the importance of systematic reviews and the founding and creation and development of the Cochrane collaboration, which has a goal of summarizing all of the randomized trials relevant to medical practice and healthcare practice in systematic reviews. How many people in this audience are familiar with a plot like this, which we call a forest plot? How many are familiar? Okay, everybody's familiar. So this is a forest plot about thrombolytic therapy after myocardial infarction. And you can see on this one that the first trial of thrombolytic therapy was conducted in the late 1950s and enrolled 23 patients, and as a result had a very wide confidence interval. The second trial enrolled not 65 patients. This is a little bit different from what you're used to. It's a cumulative meta-analysis. There were 42 patients in the second trial and a total of 65 after 2 trials. And the other numbers as you go down are the cumulative number of patients enrolled in all the trials. And you see by 7 trials and just under 2,000 patients, the confidence interval is still overlapping no effect. But by 10 trials and 2,500, it doesn't overlap the treatment effect. And we could then start thinking, when was the answer in about thrombolytic therapy after myocardial infarction? Well, if you look at down by about 30 trials and over 6,000 patients, now we have the lower boundary of the confidence interval is a long way from no effect. and the p-value is getting very low. And I think that most of us would be ready to conclude a 25% reduction in the odds of dying with thrombolytic therapy. Did this stop the trialists from continuing trials of thrombolytic therapy? No, it did not. And another 40,000 patients were enrolled after the answer was in, half of whom did not receive the life-prolonging benefits of thrombolytic therapy. Why did the trialists have to enroll another 40,000 patients after the answer was in? I think the right side of the slide gives us the answer to that question, which shows what the experts were writing in their textbooks and current reviews as these data were accumulating. Calling thrombolytic therapy anywhere from routine, only for specific indications, calling it experimental, or not even mentioning thrombolytic therapy. And I'd like to point out two things about this. One is, I'm going to see if this works. Yes. If you look at the mid to late 1980s, you see a wide disagreement about experts. Some are calling it, finally getting around to calling it routine, some for specific indications, some calling it experimental, and still one not mentioning it. And it is a decade after the answer was in that finally you get the expert consensus. And I've spoken to some of the people doing the trials, and they said, we just got to keep doing trial after trial until finally these cardiologists get it. And that's why the additional 40,000 patients were enrolled. This is a second story, again, about myocardial infarction, and it's about an antiarrhythmic prophylactic lidocaine. Now, 45 years ago, when I was training in internal medicine at the Toronto Western Hospital, I did a rotation through the coronary care unit. And we knew that patients presenting with myocardial infarction were at risk of lethal arrhythmias, and it made a lot of sense to give a nice antiarrhythmic agent, a lidocaine. And that's what I did. Every patient who came through the door, I started what we called a lidocaine drip, an intravenous infusion of lidocaine. Was there ever any evidence from randomized trials to support what I was doing? No, there was not. If you look here, right through, the point estimates are always on the harm side. Increased mortality with lidocaine. Never increased mortality was never proven, but benefit was certainly ruled out. Did this stop the experts from recommending lidocaine? No, it did not. If you look down as all these data were accumulating over a 20-year period, that you see most of the experts were recommending prophylactic lidocaine. That's why I was giving it. Although once again, you see the wide expert, yes, no, not even mentioning lidocaine. Finally, the answer was in. Now, these are old stories. They end around 1990. And although experts still disagree and they still get things wrong, perhaps not quite so badly as the stories that I've told you. Something happened in 1990 that changed the picture and made it less likely such egregious problems with expert disagreement and getting it wrong. Anybody have any idea what happened in 1990 that changed the picture? Anybody? No, evidence-based medicine didn't. I showed you that first article about evidence-based medicine. That was not till 1991, and it didn't really get steam until a couple of years after that. So something was happening that helped with the evolution of evidence-based medicine. Something else happened that changed the picture, and that was systematic reviews and meta-analysis. So before 1990, they were just appearing around 1990. And I would suggest that if the cardiologists had seen the thrombolytic therapy, they wouldn't have had meta-analysis, they wouldn't have had to enroll another 40,000 patients. And if they'd seen this systematic review, they wouldn't have been recommending prophylactic lidocaine. So big change, big evolution in how evidence is dealt with systematic reviews and meta-analysis.
Third individual with Brian Haynes was the chair of this department, the department I'm in, back when it was clinical epidemiology and biostatistics. And he chaired the department for 10 years, did a great job doing that, but also made contributions, important contributions to evidence-based medicine, which includes this article, which says, evidence does not make decisions, people do. And this had to do with values and preferences. This is Hilary Llewellyn-Thomas and Annette O'Connor, who did a lot of work in patient decision-making and values and preferences that informed what was happening in evidence-based medicine in that regard. And P.J. Devereux is now leading the world in perioperative medicine, but he conducted a study before he did that when he was still in training. And I am now going to enroll you as the latest population to participate in Dr. Devereux's study. So listen carefully. You're going to be answering some questions in a while. And what Dr. Devereux presented patients and physicians with is a situation of people with atrial fibrillation who are at risk of stroke. And the scenario is this: anticoagulation would decrease strokes in 100 patients from 12 to 4, 8 fewer strokes, few major and few minor. And the question that Dr. Devereux asked his participants, and the question that I'm asking you, is how many serious gastrointestinal bleeds would you tolerate and still be willing to prescribe as a clinician or to use as a patient thrombolytic therapy? Well, first of all, Dr. Devereux was presenting this to physicians who maybe should know this, but to patients who might not, and he had to describe what a minor and major stroke is. Minor stroke, you suddenly can't move or feel one arm and leg, difficulty expressing yourself, no pain, admitted to hospital, weakness, numbness, and understanding improve. You're left with a little bit weakness, but you can basically resume all your subsequent activities. Major stroke, much worse news. Unable to move an arm and a leg, can't swallow or control your bowel and bladder, unable to understand, talk, admitted to hospital, can't dress, walk, the nurse feeds you. After a month, you're able to wiggle your toes and lift your arm off your bed, remain this way the rest of your life with major disability. So that's a major stroke. And Dr. Devereux also described what it is to have a serious gastrointestinal bleed. Feel unwell for a couple of days, suddenly vomit blood, you're terrified, admitted to hospital, you get intubated, receive sedation, don't need an operation, get some blood transfusions, you're in hospital in a week. At the end, you are moving quickly back to your prior function. So again, here is the decision you're going to have to make. Without treatment, 12 strokes. With anticoagulation, it goes from 12 strokes to 4, 8 fewer strokes, 4 major and 4 minor. And the question to you, how many serious gastrointestinal bleeds in 100 patients would you tolerate and accept and still be ready to recommend or to use anticoagulation? Any questions about the scenario? Anything that needs to be clarified? Okay. If not, how many in this audience would be ready to accept 5 or fewer bleeds? If more than 5 bleeds, no. Who 5 or fewer? Okay. 3 people, 5 or fewer. Okay. Once you voted, don't vote again, please. Okay. 6 to 10. How many would accept up to 10 bleeds, no more than 10? Okay, a few other people. Okay, how many would accept up to 15 bleeds, but no more? Another few people. How many would accept up to 20 bleeds and no more? Another few people. Who would accept over 20 bleeds? Anybody? And a few people over 20 bleeds. Okay, very good. Okay, well, here is what happened when Dr. Devereux asked his patients and physicians. Let's look at the physicians first, the bluish color, basically a flat distribution. Here again, we had
quite a flat distribution, although maybe skewed more to the right, but still pretty flat right across, which means that some people in this audience are unready to accept any more than 5 bleeds, and some are ready to accept over 20 bleeds. Very different choices. And we have a name for those what drives those different choices, and that is different values and preferences. That's what we call it. Now, look at the patients. 2/3 of the patients were ready to accept 22 bleeds. 22 bleeds seems like a bit of an odd number. Dr. Devereux was thinking like a clinician when he did this. He didn't think they'd take more than 22. If you'd given them the chance, they would have. Okay? So huge differences in values and preferences between the physicians and the patients. The patients are much more stroke averse and much less bleeding averse than are the physicians. The physicians much more bleeding averse and less stroke averse than the patients. But there's another thing to learn from this. Although 2/3 of the patients are over there on the right, there are a few of the patients who have values and preferences more similar to the physicians and are more bleeding averse and less stroke averse. And the implications of that are that if we want to get it right with our patients, better that we use the average patient values and preferences than the physician values and preferences. But if we really want to get it right, acknowledging the variability in values and preferences across patients, we also have to pay attention to these people and do shared decision making that ensures our decisions are consistent with individual patient values and preferences. And thus, what I consider the 3 key principles of evidence-based medicine. Some evidence is more trustworthy than others, and evidence-based medicine gives clear guidance as to how to recognize more and less trustworthy evidence. Second, to get it right, we need systematic summaries of the best evidence. You see how wrong those very smart cardiologists, their recommendations when they didn't have those sort of systematic summaries. And third, perhaps an ironic principle of evidence-based medicine, evidence by itself never tells you what to do. It's always evidence in the context of values and preferences. Next individual I'd like to introduce you to is Andy Oxman. Andy Oxman worked with us at McMaster for a decade or so, then went to Norway, recently retired in Norway. But before he retired, he made a number of big contributions, one of which was a system to judge certainty or confidence in evidence from systematic reviews, which he called GRADE. And GRADE also is a system for moving from evidence to recommendations. Earlier on in this talk, I told you about the simple hierarchy of evidence that Dave Sackett introduced. Well, GRADE has brought a much more sophisticated hierarchy of evidence that works, as I'm going to show you in the next slide. But before that, to show that why I feel comfortable telling you about GRADE, it's been adopted by over 120 organizations worldwide, including prominent ones, World Health Organization, major American organizations, American Thoracic Society, American College of Physicians, the National Health Service in Britain, the Cochrane Collaboration, and the #1 worldwide source of information for clinicians, electronic text, up to date, which has over 10,000 graded recommendations. And here is the new, considerably more sophisticated hierarchy of evidence. Evidence, according to the GRADE system, is high, moderate, low, or very low quality or certainty, synonyms. Randomized trials at the top of the hierarchy, still at the top of the hierarchy, but high certainty evidence may not stay as high certainty evidence. Risk of bias, unconcealed, unblinded, lots of loss to follow-up. Imprecision, small sample sizes, wide confidence intervals. Inconsistency, some trials suggest benefit, some don't. Publication bias. We're misled because some of the trials are not published. And what we call indirectness. I work as a secondary care internist, hospital-based internist, and I try to manage my patients on the basis of randomized trials that inform my practice. However, nowadays, lots of my patients are over 80, and quite a few nowadays are over 90. Not too many over 80 and very few over 90 in those randomized trials. Maybe I can't be quite as confident applying it to these very old patients as younger. The trials in the younger patients, according to the grade way of thinking, provide indirect evidence for my older patients, and that indirectness makes me less confident. So we have randomized trials start as high certainty, all these reasons for rating down. Observational studies, non-randomized studies, start as low certainty evidence. How many people in this room take care of patients in their day-to-day lives? Not too many. All right, so I can't, the question I would ask if there were lots of people is, and maybe you can, maybe those who do can try, is there anything you can do that you do in your clinical practice that you know works, no question, big effects, even though no randomized trials? Moet, back when you were actually doing orthopedic surgery, what did you do for people that you were sure worked, had a big benefit, although no randomized trials? Okay, so Moet, you know me very well. Is there anything that I have done that you are sure has helped me, even though no randomized trials? Have you forgotten that I've had 2 hip replacements? Okay, and there is an intervention that has a major benefit, even though there's no randomized trials. And fortunately, my hip replacements have worked out quite well. But there are other things in medicine. There is giving dialysis to patients with what otherwise would have been terminal renal failure. There is insulin in diabetic ketoacidosis. There is epinephrine in anaphylactic shock. And for all of these, the common denominator is very large effects. If we have very large effects, as in those situations, we don't need randomized trials. So observational studies start as low, but may even end up as high with these very large effects. So now we have this much more sophisticated hierarchy of evidence that grade applies. There we are. Okay, but grade, so that's how grade rates the certainty of the evidence. But grade also tells us a way of going from evidence to recommendations. 2 categories, very simple: strong recommendations where the benefits clearly outweigh the downsides or vice versa, or weak or conditional recommendations. What can move us from a strong to a weak or conditional recommendation? If there is low confidence or certainty in the evidence, well, if you say, I'm going to make a strong recommendations if the benefits clearly outweigh the downsides, or vice versa, but I'm not sure of the benefits and downsides, pretty difficult to make a strong recommendation. Or we're pretty sure about the balance, we're pretty sure about the evidence about benefits and downsides, but we've learned that evidence never tells you what to do. It's always evidence in the context of values and preferences. And if it's a close balance between the desirable and undesirable consequences, people with different values and preferences are going to make different decisions, warranting a weak or conditional recommendation. So there is one question as I go around the world, I have the privilege of talking to clinical audiences. There is one question I ask them wherever I go. I get the same answer, and it's unanimous in these clinical audiences. And that question is, do you have enough time to spend with your patients? Are you happy with the time you spend? And the answer, wherever I go in the world, is universally, no, I don't, and unanimous or virtually unanimous in every audience. Now, the grade approach to strong or weaker conditional recommendations helps with the problem. You see, we don't have enough time. We got to ration our time. How should we ration our time? So, strong recommendations, if a panel has got it right, means that all or almost all fully informed patients would make the same choice. Weak recommendation, or conditional, choice would differ across patients, usually because of different values and preferences. And that has implications for how we should interact with our patients. If a guideline panel has got it right and have made a strong recommendation, it means that everybody or almost everybody, if you did take them through a shared decision-making exercise, would make the same recommendation, just make the same choice. Well, we know we don't have enough time for our patients. That's not a good use of our limited time. Just to say to the patient, here's what I think you should do, here's the reason why, let's go for it. However, with a weak or conditional recommendation, because of different values and preferences, the choice is going to differ. And in other words, then, to get it right for the individual patient, you need to go through some shared decision-making exercise. And decision aids can help you. The time to use it may not be a good use of time for a strong recommendation, but it was in a weak and conditional. And in a moment, I'm going to show you a particular approach to decision aids. We're still working on it, but a big advance that we've seen recently in decision aids. So, guidelines, average values and preferences, that's all you can do. You're making a recommendation for a whole population, but at the point of care, you need, when we're uncertain of the evidence or the balance between the upsides and downside is close, we need to do shared decision making, and it's challenging. Decision aids can help. This is Victor Montori. Victor Montori is a professor at the Mayo Clinic. We had the great privilege of having Victor here for a couple of years, where he started into what has become groundbreaking work on patient decisions. And he's a diabetologist. So he sees a lot of people with diabetes, and nowadays there's lots of different treatments that we can use for diabetes. And Victor wants to help his patients make the right choice. And he has these cards, and these cards say various things that happen differently across the medications. So they had different effects on weight, on the unfortunate consequence of hypoglycemia, on the reduction of blood sugar, daily routine, sugar testing cost. Now, of those 6, what is your guess in Victor's practice about the most popular first choice? He asked the patient, which would you like to see first? What do you think is the most popular first choice? Cost? Nope. Nope. Yes. Number 1, about 40% of the patients want to know first about weight change. And then they could ask about daily routine. And then they could ask about cost. And they could end up asking about all 6, but they never do. They typically stop maybe 4, more common 3, sometimes 2. That's all they need to know. Think of the efficiency that this creates. You don't tell them about everything. You tell them about what they want to know. So this is individualized shared decision making. And now, Andrew, we are going to show a video. Andrew's going to make sure this works right.
Yes.
Okay, we'll give Andrew a second.
It's being live streamed and zoomed, and also this, so we have to ensure that everyone can hear it.
Okay.
Most importantly, yourselves. Bear with me one
The
second.
people in the room definitely have first priority.
That's it, so. Hopefully they didn't hear that online. Okay, pardon me a second.
Okay, let's see. Can I start? Not working this way. Just touch the screen. It worked when we tested it. Well, you can at least hear it. Well, maybe you can't. I heard it. I don't know, Andrew. This might not be worth it. Hey.
So that means so we tested for your next evidence. Yeah, you're already on the phone. Yeah, it's actually very easy to have the whole thing.
So, evidence-based shared decision-making in 90 seconds. Doesn't always go that smoothly, but you can see that these cards can be really helpful. Okay, I'll give you a minute to go back to the thing. But the next people I'm going to introduce you to, we're getting a bit of an echo here, but I'm sure that'll stop shortly, are two local ICU physicians, one of whom is here, Maureen Mead. The other one who is not here is Deborah Cook, although she was hoping to be here and has been traveling. And I'm going to particularly present to you something that Deborah Cook has done, which is what I think is a really amazing innovation in evidence-based medicine called the 3 Wishes. And the 3 Wishes project is one that Deborah initiated, I don't know, 10, 20 years ago, and has had a big worldwide influence. And you'll see there are Deborah and Maureen, along with the other people that I've introduced you to. And in a moment, I'm sure we'll get this back. The 3 Wishes is approaching patients who are at the end of life in the intensive care unit and presenting them for ways that their end of life experience can be more meaningful and more meaningful for their families. And now I need a little help from the slides, perhaps. So what Deborah has done is to present the families and the patients with special things that would make their end-of-life experience more meaningful. And it can be something as surprising and innovative and taking a lot of work, like, there we are, like a marriage ceremony happening at the bedside, or simple things like the flowers at the bedside. So the objective is to improve the dying process, honor patients' dignity, humanize the dying process, and for clinicians inspire a deeper sense of vocation. Wishes for the patient, family, friends, or clinicians. Deborah is a scientist, so she has done a mixed method study to look at the impact. What matters most at the end of the life is usually simple. Eliciting and implementing wishes helps to personalize the dying process. The 3 Wishes Project gives voice to the family and calls forth clinician compassion, and it's an approach to end-of-life care that has been widely adopted around the world. Really, in my view, a marvelous contribution. So, Per van Veek was here for a year with us to work on a guideline on thrombosis that we were creating. And his question has been, how can we provide evidence-based guidance efficiently? And we produced what we thought was a nice guideline, but Per said, is it really available, useful, and understanding for clinicians? Maybe not. Is it suited for integration into electronic medical records, textbooks, and adaptation? Certainly not. Does it facilitate shared decision-making? Not at all. Something needs to be done. How can we make grade irresistible for clinicians, patients, and developers? And what Per decided we need is MAGIC, which stands for making grade the irresistible choice. And part of MAGIC is what we call, one of the things that Per was realizing, along with making these guidelines most useful, is that they needed to be up to date. And so typically the way guideline organizations produce their guidelines, they all get together, they get a big panel, they do a lot of work, they summarize the evidence if things are going well, and they make all their recommendations. And at the end of it, they are so exhausted, they go off and they don't do it again for 2 or 3 years. And you can imagine what happens during those 2 or 3 years. All sorts of new evidence comes along that making really problematic. And so what we need, people are now realizing we need living systematic reviews and living guidelines. And to kickstart the process, Per, on behalf of MAGIC, negotiated with the British Medical Journal to produce what we call BMJ rapid recommendations. We monitor the literature, find the latest practice-changing evidence, quickly do systematic reviews, quickly set up the guideline process, the trustworthy guideline process. This in 2016 were the first of these BMJ rapid recommendations, and there have been many since that time. And what helps us is the MAGIC app, which is a publication platform we use. It is a guideline authoring and publication platform that allows us to produce multi-layered guidelines, which I will show you, and put them on your smartphone. And that also allows integration into the electronic medical record, adaptation to different places, and the semi-automated production of decision aids. And the Thomas Agaritzis, who did his PhD with me and with Brian Haynes, and has subsequently worked very closely with MAGIC, now in a leadership role, has helped in particularly with this semi-automated production of decision aids, which allows the evidence structured on grade principles. Victor's notion of efficient patient choices has allowed this semi-automated production. And Romina Brignardello, who is here, and Reed Semenchuk have been producing in the time of COVID, to do these living systematic reviews, and another EBM innovation, a network meta-analysis that allows the simultaneous comparison of many different treatments. And this work that Romina and Reed did informed the WHO guidelines. And what Per did next is he negotiated between the BMJ and the WHO that when the WHO produced their guidelines, they would appear at the same time in the BMJ. So now for 2 different audiences, the WHO audience and the BMJ audience are different, but they see the same guideline at the same time. And an important part of this is what the MAGIC app can do for this. And if this works, there we go. Let's see. So we're going to enter there we are in the WHO guidelines. And the WHO guidelines, is this working? Oh,
Sharing and then share that instead. It's this magic app.
it was looking very good on my screen.
Yes. Recommendations for patients with
Yep.
non-COVID-19.
You got it. Thank you. Okay, so as it turns out, for patients with non-severe COVID, nirmatrelvir ritonavir is the best treatment. And so as a result, the WHO makes a strong recommendation for this treatment, but only though for those at high risk of hospitalization. You notice the color coding in green. But for patients at moderate risk, much lower risk of hospitalization, it's only a conditional recommendation or weak recommendation. Hopefully we'll get through this. A conditional recommendation for patients with non-severe COVID. That conditional recommendation below it is some key elements that clinicians need to know. For instance, there's a lot of interactions with other drugs. But patients could go, the clinicians can go to the research evidence. And if with the research evidence, you see something called an evidence profile, which tells you about the relative effects, the absolute effects, and the certainty of the evidence for the key outcomes. And you see mortality and admission to hospital appearing several times, different for the high, medium, and low risk groups. And the clinicians can go to the evidence to decision framework, the benefits and harms, the certainty of evidence, the values and preferences that we know are crucial, resources and others. They can go to a justification. They can go to practical information about the route, dosage, and duration, and other aspects. Some clinicians may just say, what's the recommendation and what's the practical? They don't need to look at the other stuff. Some other physicians may be interested in the decision aids. And so you can go to the decision aid. The first two are the high risk, the second two, the intermediate risk conditional recommendation. And it's an interaction. The clinician can guide the patient to the hospital admission, which is where the action is. And as it turns out, your risk is 30 in 1,000 or 3% of hospitalization without nirmatrelvir, ritonavir, 5 with, pretty good relative risk reduction, rather smaller absolute risk reduction. Patients may have trouble with the numbers, so you can show them this, which is 1,000 people represented by these symbols. And it says the black and the orange are the 30 who would need hospitalization without nirmatrelvir, ritonavir. The ones in black are the ones who will still need hospitalization even with it. And the orange are the 25 in 1,000 who are prevented from having hospitalization with nirmatrelvir, ritonavir. So here's how the magic app can help you. We are coming to the end, and I think the next slide tells me about EBM in the time of COVID, which I think is a triumph of EBM. So what we were able to do is to do these large trials using innovative trial methodology of platform trials. Within 2 years into the epidemic, we had 3 classes of drugs which lowered mortality in people with severe and critical illness, and we had 3 drugs that lowered hospitalization in individuals, thank you, with non-severe COVID. And how come it's not changing? I can change from here, it's okay. There you go. Okay, so we have these platform trials. Unprecedented cooperation among the trialists. They actually published their stuff before it went into the big channels. Rapid sharing, the WHO collaboration with MAGIC and the BMJ with these living meta-analysis and living guidelines coming out very rapidly. The way EBM should optimally work. And so, in conclusion, the 3 principles are widely acknowledged. The hierarchy of evidence. Some evidence is more trustworthy than others. and now a very sophisticated, well-working way of differentiating between more and trustworthy, less trustworthy evidence, the GRADE approach. The need for living systematic summaries, so you don't make the sort of disastrous mistake that these very expert cardiologists were making before 1990, a decade behind the evidence, or recommending useless treatments. The importance of values and preferences, the crucial third principle of evidence-based medicine. Evidence itself never tells you what to do. And my computer just died. That may be the explanation for this. So finally, these three principles are now widely acknowledged and adopted. And as a result, evidence-based medicine has changed the world. Thanks very much. Question, or Peter, do we do questions and comments now? Okay, anybody have anything you would like to ask or comment about any of what we've been through? Yes, Mitch.
So back to the PJ's study, the atrial fibrillation.
Yes.
Patients and physicians disconnect.
Yes.
Is what matters most.
Yes.
One of the things that we discovered, we had a similar study like
Yes.
was that the physicians, this is their value system that was operating. I don't know how you deal with this. That's my question to you. Their value system was, if the patient bled on the anticoagulant, I caused the problem.
Yes.
If the patient has a stroke because I didn't treat them, the patient caused the problem. And it was that disconnect that actually drove their behavior to underprescribe these drugs.
Yes.
How do, the evidence is the evidence. How do you deal with that kind of
Well,
situation?
you persuade clinicians that what's important is not their values and preferences, but the patient values and preferences. And one thing that helps that is, since physicians are very dependent now, or rely very much on clinical practice guidelines, to make sure the guideline developers are cognizant of the fact that they should be using patient values and preferences in making their recommendations. So the recommendations, and if physicians understand weaker conditional recommendations, you tell them this is shared decision-making. So you're trying to lure the clinicians into using shared decision-making so that decisions at the bedside are the decisions that reflect the values and preferences. And I would say now there is universal recognition that shared decision-making is crucial. Nobody would say, no shared decision-making. Whether they do it, it's challenging. Whether they do it or not, and do it as conscientiously, and they should, that's another matter. But we're on our way in that I would say it's universally acknowledged, at least in the West, that shared decision-making is necessary to get it right, which means use the values and preferences of the patient. Jonathan, did you have your hand up? Yes.
Not being a clinician or practice PBM, it just seems like there are very pragmatic solutions to dealing with big problems, steeped in methodology developed. And you mentioned this morning the idea of getting this into curriculum early, primary school, et cetera. Just curious to know if you can pontificate a little bit, so you don't have to have knowledge, but you can just speculate. How can that be done? Like, how can we, just think about Ontario, where you've got a cash-strapped system where they're constantly stuffing more kids into a classroom, less teachers, and so they're just pushing kids through. How do we stave the risk of having individuals not know how to make proper decisions and bring this into curriculum?
Those of you who were at the other session, I told the story of Andy Oxman's randomized trial of putting a system into a cluster randomized trials. Some classrooms get the approach to what he calls informed health decisions, and some do not get it. And in his randomized trials, the kids got it, and in the nifty finding, when he tested, he used the same test for informed health decisions with the parents of the The parents of the kids actually improved. The kids went home and taught the parents. And where did he do this? He did this in impoverished East Africa. That's where he started. Crazy it seemed to me, but he pulled it off. Jonathan, if Andy can do it in impoverished East Africa, surely whatever the challenges to our education system, we should be able to do it here. It's a will. It's getting the educators to realize this is a crucial potential thing. This would, and we talked in the earlier session, what do we do about misinformation? Misinformation is driven by people not able to make informed decisions, never have been taught about informed decision making. We need to get into the schools, and it is, if Andy can do it in East Africa, surely we should be able to do it here. Yes. We need another major change in the United States to allow that to happen. There may be people in the United States who don't want people to be able to make informed decision making. That is possible. Yes.
So you gave an example of how the working together of BMJ and World Health Organization and MAGIC really generated very quick guideline recommendations, and they were put out to the world. And we were talking about COVID, but in general, when new practice-changing information comes out, how quickly are BMJ, Rapid Rex, and MAGIC-Cap, and sometimes the WHO getting that out there?
Well, it depends. So what you're distinguishing between publishing it on the WHO website, publishing in the BMJ, and people actually adopting it in practice. No.
COVID was a situation.
Yes.
So with thrombolytic therapy, it was like 20 years.
Yes.
But is it, in general, when it's non-COVID, is it still getting out like in a matter of
No. So what COVID is a great point. What COVID told us is if we put the energy and the will and the resources in to do it, we can pull it off. But immediately after, complacency sets in and it doesn't move in the same way. Now, the guideline organizations are beginning to get it. So they are beginning to say, we can't do this do it and then wait 3 years and do it again. We need to make the systematic reviews living. I think we can do that now. Again, it requires some energy and resources, but we have the methodology, and that's only going to get better with AI. We're going to be able to do the systematic reviews more quickly. We're going to make them the AI is going to help us do all the processes more quickly. So we should be able to do it quickly. And then we should be able to put, we have done it at the WHO level. We should be able to put these guideline panels together. My notion is each of these organizations should have a standing panel or a number of standing panels ready, which is what the WHO does. I don't see why the rich organizations cannot do it, having standing panels ready. And new recommendation comes up, you pull the panel together on Zoom and you deal with it. That's the way we've done it with WHO. It'd be every month if it depends the area you're working in. Maybe you're in an area where every month or two there's a practice changing. Probably nothing when it's that frequent, but some more frequent, some less frequent. You do it, ideally you do it for every practice changing trial.
But I mean, how long will the process take for each new?
Well, our target was 90 days. We didn't make it in 90 days all the time, that's for sure. But that's a aspirational target, which is not completely unrealistic, I think. Yes.
I have searched and read about 2000 guidelines, and I find a problem that I may fail health. because some guidelines they should say that they use the grid, and some of them use only grid for the certainty of evidence, and some of them use only for the recommendation, and some of you use the grid for the votes, and even other guidelines state that they use the grid in the method section, but in the summary and in the evidence section, it seems that they didn't use the grid.
Okay, so what you are labeling is there are more trustworthy guidelines and less trustworthy guidelines, correct? That is the essential. And Mariam Kadimi, who has just completed a study which she has looked at what things were like 20 years ago and what things are like now about trustworthy guidelines, and developed an excellent instrument for measuring the trustworthiness of the guidelines, and has found that there is improvement over the last 20 years. Unfortunately, not great improvement, modest improvement. But 20 years ago, she found 2% of the guidelines met high trustworthy standards. Now, it was 18% of the guidelines met trustworthy standards. Seems like a sad story, except if you can find in your area, I would think almost every area in medicine can identify somebody who's putting out trustworthy guidelines. I'm hugely biased because I've been working for the last 15 years with UpToDate to get them to produce trustworthy guidelines. I think they're doing a pretty good job. If people go to UpToDate, I think most of the time they're going to find trustworthy recommendations. So yes, it's only a small proportion, but maybe all we need is a small proportion to doing trustworthy guidelines if clinicians can recognize where to find them. Yes. Thank you.
My question is regarding the future of evidence-based. What do you think are the main challenges for the next stage or the natural evolution of evidence-based medicine? Given the current context we have, a lot of information, misinformation, IA, what do you think is the future of evidence-based medicine? What are the main challenges?
Okay, well, Mitch identified one challenge. The physicians not having the same values and preferences as the patients and not recognizing it. I suggested that there are some solutions in the process, but again, I think to really do it, just like you have to teach the kids in grade school, you have to teach the physicians in medical school. In other words, medical schools should be emphasizing the necessity for shared decision-making and using values and preferences. Maureen has said, can you really get these processes, the new information, and get a trustworthy guideline out quickly? And I said, well, I think so, but we certainly could be doing better. And as I've suggested, AI might help us doing this. And we need more, the shared decision-making is challenging. We need more Victor Montori approaches, and we need to teach in medical school again, and residency training. We need to teach people to use these approaches to actually do shared decision-making with their patients. Those would be three major areas that we still can be working on. All right.
Thank you.
All right.
Are we on? Sounds like we are. Yep. Great. So that was a great lecture, and thanks to Professor Guyatt, Professor Bauman, as well as the audience for their contributions and participation. Personally, I learned a lot about a clearly developing field of evidence-based medicine, even after 30 years from its inception. We wish to thank the VP of Research, Jonathan Bramson, from Faculty of Medicine, McMaster, as the lead sponsor for this event. So thank you, Jonathan. The Friesen Prize and its related events today are organized by our colleagues at the Friends of CIHR. We have a board of 11 and an executive of 4. And Andrea Baum is actually vice president on our executive. So I wish to thank all of them. We're very much looking forward to our planned visits coming across Canada in the next 2 months. Regarding the Friends of CIHR, I did want to mention a couple of items. I think I mentioned at the beginning, this is the 25th anniversary of Friends of CIHR and CIHR, and we're working with the CIHR leadership as we speak to develop a plan for a fall event in Ottawa to celebrate those anniversaries. So you'll be hearing about that in due course. Finally, I wanted to encourage faculty and trainees to consider becoming a member of the Friends of CIHR. So if you're interested in doing that, you can go to our website. It's a very simple website, fcihr.ca, and there you can sign up. So again, thank you for hosting us, especially to Professor Andrew Bauman and Andrew Carabine and Caitlin Kemp, I think still online. So please have a great rest of your day. And I think we're going to have some refreshments. So thank you all.